I know most of you, like Tanna sir said, ki ATLS, the role you probably think is when there is a broken leg or broken hand. But what if you are a doctor and there is a patient lying on the street with a accident and with grievous injuries? The probably the lay people will come to you, and at that point of time probably a little small information about how to approach that patient should always be there for every doctor. So I'll be discussing about the airway approach, because without breathing the patient is going to finally succumb to death no matter whatever we do for that patient. So when we approach a airway, how do we approach? Like, when we talk to the patient, just talking to the patient at the first instance, what we do in the BLS also will make us recognize that the airway is patent, because if the patient is talking, that means the most probably the patient doesn't have any airway jeopardy. How to recognize the problems? Like, patient is agitated, there is tachypnea, there is obtundation in the sense he's very drowsy, or there is severe cyanosis, bluish discoloration of the nails and the skin. That shows that the patient has hypoxemia. Snoring or gurgling. There are so many times when the patient is just drowsy and there's a weird noise which he's making, that also indicates that the patient's airway is not patent. And of course, hoarseness of his voice. So everything. Why hoarseness is important? This is important mostly in burns patients, or there is a laryngeal obstruction or laryngeal fracture in certain kind of facial and head and neck traumas. So these problems we have to immediately recognize and then go ahead and do the treatment about it. Yeah. So, who are the patients who are of increased risk of airway compromise? These are the most common we see are the maxillofacial traumas, like facial burns or inhalational injuries, like I said, mandibular fractures, or who have received muscle relaxant sedations. Probably this is not where the trauma comes into. Neck trauma, where there are penetrating injuries or blunt injuries of the causing cervical hematomas, or laryngeal traumas. So this the helmet removal is a very, if there are so many times when we see a two-wheeler, this doesn't work. We are anyways going to show all this on the hands-on sessions. So I'll skip this. But in trauma, the basic thing is airway comes with the cervical motion restriction. Why? Because so many times in the head injuries, the cervical spine is involved, and if the patient is moving the neck vigorously, or while taking care of the airway we are moving patient's neck vigorously without taking care of that cervical spine, then we know that if there is a C1 or C2 fracture, we are anyways going to lose the patient. So, how we predict the difficult airways? Difficult airways is when we know that even if we are trying to, secure a airway, it is going to be difficult. The cervical spine injury is the most important. Significant facial trauma, if the patient has a history of arthritis, limited mouth opening, what we see, obesity, and anatomical variations. Yeah, difficult airway assessment. I understand that this is probably not at all related to orthopedic guys. This is what mostly Dr. Hemant Mehta and his team, Parna ma'am, they see. And sometimes we in the emergency department see. So, but just for the knowledge, we should know that there's something called Lemon to detect the difficult airway. Lemon, L stands for look at the patient's anatomy, basically to look at his anatomy, like the small mandible or a large tongue or a short bull neck. This says that the patient will have difficulty when we are approaching him for a airway. Evaluate, E stands for evaluate, that is the three and two finger rule, where we we find that the width, we see the width between two teeth, and or hyoid and mentum, or hyoid and thyroid. Then there is Malampatti scale, which you must have heard about. Malampatti scale goes where we have shown the diagram about it, where we see the opening, where when we are, the suggested airway obstruction. If the opening is very less, we can't even see the, that there is no difference between the tongue and the, what we say, palate, hard palate. Then we definitely know that this is going to be a difficult airway. Then we O is obstruction. Obstruction because of secretion, stridor, muffled voice, neck mobility also. That's how the inline immobilization comes. And inline immobilization itself can become a little difficult for the when we are approaching a airway. Now, most important, which for people who are not very trained in advanced airway, these few procedures are for them. For maintaining a airway, when we think that the airway is not very badly obstructed, can be maintained with these few procedures. We all know, probably we have heard about it when we were learning BLS ACLS. There is something called head tilt, chin lift. These all we will be seeing in our hands-on sessions. Jaw thrust, nasopharyngeal airway, oropharyngeal airway. These things, when we do, and if the airway has got maintained, then we don't have to go for a definitive airway. Also, for people who don't know how to go for advanced airway, can use supraglottic devices. Supraglottic devices are for, even for a layman, for paramedics, for doctors who don't know how to intubate. Supraglottic devices are the best. They you just can blindly put them and your airway is maintained. Some of them is like laryngeal mask airway, laryngotracheal airway. Again, this probably will just see in the, yeah. So these are the laryngeal mask airways. See, as you can see, it is almost similar to the endotracheal tube, but this can be put very blindly. So it is not very difficult. Anybody can do. You guys can do. If the anesthetist or we guys are not around, if the critical care people are not around, and you have to, because the oxygen is not coming out, you have to save the patient, you can just use this. So definitive airway, as I was repetitively talking about, definitive airway is of three types: orotracheal, nasotracheal, and surgical. First, we always commonly use a orotracheal intubation. Nasotracheal comes in picture if there is suspicion of head injuries and maxillofacial injuries. Surgical airway, when both of the above are not helping, none of it is helping, and the patient's oxygen is just dropping, then the last thing which comes in picture is a surgical airway. Surgical airway is cricothyroidotomy and tracheostomy. I'm just mentioning this. I know that you people will not be at all interested in it, but you have to at least know it. Then criteria for definitive airway is inability to maintain patent airway, inability to maintain adequate oxygenation, combativeness resulting from cerebral hypoperfusion, and GCS, of course. GCS less than 8. Not every time the saturation being low, or or in cardiac arrest we intubate a patient. We also intubate a patient when the patient's GCS is low. That in trauma we can see in head trauma basically. Now, just in case, I will mention about objective signs of inadequate ventilation. Basically, we have intubated the patient, but the patient's oxygen levels are not rising. How we can see that is when there is unequal rise or fall of the chest. When the patient, you can see that the patient's chest is not rising. This is something which we can see by our own eyes. Or absent breath sounds or decreased breath sounds when we auscultate the patient. Also, we can see this when we see a pulse oximeter, which is a very normal thing, and a capnography or a ETCO2 as we say. This we have to at least, when we see a problem, there's a airway which is put and the oxygenation is not happening, and the patient is there, the team has left and you people are there. If you think that the oxygen levels are dropping or not rising up, at least you recognize the problem and you can then call for help. Other most important thing which we as emergency physicians always follow, and I always think that everyone should follow, is again and again go back and re-review the patient. So if the airway is maintained, the team has gone and you are there managing your limb trauma and everything, but as a doctor, I always feel that even you can re-review his airway, thinking that if the patient is again deteriorating, you again can call for help. Yeah. So from my side, this is it.